Dear Chairman, dear colleagues, thank you for letting me presenting my work. I have no conflict of interest. So we know that mid-urethral slings implanted for urinary incontinence can cause high rates of pelvic pain that range from 0 to 30% in the literature. And surgical removal of those tapes can improve pain in 68% of cases, but it is associated with a risk of urinary incontinence recurrence. And there is no consensus yet to know how to manage the patients that have urinary incontinence recurrence after tape removal. So we conducted a retrospective monocentric study of all patients who underwent tape removal in our center between 2004 and 2016. TUT was removed by vaginal incision and tight dissection, and TVT, they were removed laparoscopically. And the main evaluation criteria was urinary incontinence management after tape removal. And we also evaluated the continence at the end of the study, and continence was defined by 0 or 1 pound per day. So 89 patients were included in the study. Urinary incontinence recurrence occurred in 58.4% of patients, and among them, 25% were still painful. Stress urinary incontinence was present in 71% of patients who had urinary incontinence, and 24.5% of patients had mixed urinary incontinence. Median follow-up was 41.4 months. 19 patients had TVT removed, 31 TUT removed, and 2 patients had TVT and TUT removed. Among the patients who were incontinent, 32.6% of patients refused any treatment, either because they were still painful or because they fear of having de novo pain. 26.9% underwent conservatory treatment alone, either antimuscarinic or pelvic floor muscle training, and 40% of patients underwent surgical treatment. Among them, 10 patients underwent TVT placement, 4 Birch colpost suspension, 4 ACT, 2 artificial urinary sphincter, and 2 underwent sacral neuromodulation. And after reoperation for urinary incontinence recurrence, 6 patients were still incontinent. And among them, 3 underwent IUS implantation afterwards. Only 1 patient who underwent bunch procedure had de novo pelvic pain, and the overall continence rate at last follow-up was 82%. So as conclusion, 58.4% of patients experience urinary incontinence recurrence after mid-urethral sling removal. Almost 40% of patients will undergo surgery with a low risk of pain recurrence, and overall continence is achieved for 82% of patients. Thank you very much.
Thank you very much. This paper is now open for questions, and perhaps I could ask the first question. If someone's had a tape removed for pain or erosion, how do you then counsel that patient to put another synthetic mid-urethral tape in?
Yeah, that was the main subject of our discussion. First of all, autologous slings are not recommended in France. And when you see, we performed Birch at least at first, and there was one which was still painful. And in our experience, when we removed the TVT tape, we saw that the patients who were painful, it was because the tape was implanted too laterally in the muscle. So the idea was that if we implanted the TVT correctly, not in the muscle, the patient should not be painful. And we didn't implant the TUT because obviously there is a much more pain with TUT, and we cannot control the implantation as well as TVT.
It's just, I think I'd be very, 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 very wary about putting a tape in someone who'd already had a tape complication. Jerry?
That was my point. Jerry Blavis from New York. How long was your follow-up after the secondary operation?
40 months.
14 months?
14.
I'd be concerned about longer-term complications, particularly with a sphincter or another mesh sling. I mean, in the States, our guidelines say that you should not put another mesh sling in someone that's had an erosion, at least from a prior mesh sling. And I'd be very worried that in the long term, there's going to be more erosions. I mean, only time will tell.
Yeah. I think we perform a much larger dissection of the mesh because of the pain. We did not incise only vaginally. We also performed thigh dissection and laparoscolically in TVT. So maybe the extended dissection can cause this higher rate, I think.
Do you ever offer partial resection?
Yes, we offer partial rejection when there was a trigger zone in the vagina because the mesh was too tight. Yes, we could offer vaginal incision. But when there was a hypersensitivity or neurological symptom, we perform tight dissection and complete removal of the sling. It's possible.
And Chiara?
What evaluation and treatment of the pain occurred prior to the explant, and what percentage of patients had physical therapy prior to explant?
All patients had physical therapy prior to explant, and they were seen in a multidisciplinary pain consultation with a pain physiologist prior to the surgery.
Just a short question. Jonas Gunnarsson here from Göteborg. I just wanted to ask you, since you are getting into this with a pain problem, did you get any idea what actually elicits the pain in these patients? Is it the insertion, the passage to the rectus muscle, because you refer to the muscle without saying what muscle? Or is it in the perineal diaphragm? Is it there you have the problem? Where is it?
For in the TOT, it is
the TVTs.
In TVT, it is the levator ani muscle on the laterally to the fascia.
And nobody goes through the levator.
The muscle. I don't know the term in English. I'm sorry.
Well, first you pass the pelvic diaphragm, then you go up to the rescue space,
yes, but
and then you go through the rectus muscle.
Rectus muscle in the
abdominis rectus.
When you are too laterally closest to the iliac vessels, there is a muscle just behind the fascia, and it was there the tape.
That's not according to the treatment protocol, really. Thank you.
Welcome.
Thank you very much.
Thank you.